You're listening to ReachMD, and this is Lipid Illumination, sponsored by the National Lipid Association. I'm Dr. Alan Brown, your host, and joining me today is Dr. Harold E. Bays. Dr. Bays is the Medical Director and President of the Louisville Metabolic and Atherosclerosis Research Center in Louisville, Kentucky. And he's served as an investigator in over 400 phase 1 through 4 clinical trials for the treatment of high cholesterol and other dyslipidemias. Today we're going to be discussing the evolving treatments in lipid management, including the role of niacin, the status of laropiprant, a brief overview of fish oils and omega-3 fatty acid supplements, as well as the novel approaches being used in today's new lipid-lowering therapies. Thank you very much, Dr. Bays, for joining us.
Well, thank you very much for having me.
So as you know, there's a lot of controversy about some of the more recent combination therapy trials when adding agents on top of statins, including AIM-HIGH. And some people have taken the AIM-HIGH data to mean that we should not use niacin in clinical practice, which I know is probably not either one of our positions, but I'd like to hear a little bit more about where you think the role of niacin is in dyslipidemia based on the AIM-HIGH data.
Yes, I think that's a very good point. I think a message that seems to get lost sometimes is some of the older data suggests that it at least as monotherapy and in combination with some of the older agents, niacin did seem to have benefits with regard to reducing cardiovascular events. So I think that's important to keep in mind. Having said that, it's certainly true that the AIM-HIGH study suggested that if you have really well-controlled LDL cholesterol levels, with LDL cholesterol around 70 milligrams per deciliter or less, and you were able to achieve that with statin therapy, if you added niacin, that extra niacin, may have not afforded any additional benefits, even though the triglycerides were reduced or the HDL cholesterol was raised. Now, a lot of people bring up, potential issues they have with the study design and such, but the good news is we have an upcoming study, the HPS2 Thrive study, which is a much, much larger trial, in this case looking at niacin with the flush blocker known as laropiprant, and comparing that along with statins compared to statins alone. So I think we should have a more definitive answer, hopefully by or before the mid part of next year.
Yeah, it's very interesting because not only did people have LDLs in their 70s in AIM-HIGH, but 94% or so also had triglycerides that were relatively low, and so they were not only at their LDL goal, but they were at their non-HDL goal. So at least what I took away from that trial is trying to raise isolated low HDL in a patient whose LDL and non-HDL are at target does not appear to bear much fruit. But there were so few people with triglycerides over 200 that theoretically we would generally be thinking of as having residual high non-HDL. You really couldn't say much about that subgroup. And what I don't know, and you might have some insight on this, is whether or not the HPS2 Thrive baseline triglycerides are relatively high, or are we going to suffer from that same issue that we're looking at patients that are at both their LDL and non-HDL target?
Right. I think you're putting your finger right on the issue that we have, not just with, the whole niacin development program, but frankly, with all of our outcomes trials that we do. And that is, once you achieve these very aggressive, treatment targets and such, to then require that there be this additional benefit with an additional drug is challenging no matter what the drug is. And unfortunately, that's not really what we see in clinical practice. In clinical practice, we see a lot of patients who are not able to achieve these very aggressive lipid treatment targets. So to me, anyway, as a person that does these trials all the time, I find it just interesting and somewhat disappointing that we're not able to, put people in that more reflect what we see in clinical practice.
Sure, makes a lot of sense. So on that note, we recently had another meta-analysis on omega-3 fatty acids. And, depending on which side of the issue you lie, there have been criticisms and praise. But I'd love to hear your thoughts on what you think about this recent meta-analysis of the clinical trials for omega-3s that suggested that at least supplementation in the form of pills didn't seem to translate into a reduction in cardiovascular events.
Yeah, I think that's unfortunately, I think that's how it was characterized by the media, but that's not how one should interpret a meta-analysis. a meta-analysis is simply a collection of relevant studies, and whoever is doing the meta-analysis can determine exactly what criteria is used in order to incorporate specific studies into the meta-analysis. And then a specific p-value has to be assigned to determine if that's clinically significant or not. And simply because something didn't achieve a specific p-value that was set by the people doing the meta-analysis doesn't mean that the therapies were not effective. It just simply means it didn't achieve a level of significance that the authors put. And in this case, the authors put a p-value of 0.006, which was a bit unusual. Okay, so a bit unusual. So I would just caution clinicians and patients, when you have studies that had been conducted for years, well controlled, and had undergone a priori evaluations for statistical analysis and a dedicated clinical trial, and again, trials that have over years, I think it is probably not wise to say, well, we did looked at a meta-analysis, which, once you have all the data and you have the software, it doesn't take very long to do, and we have somehow concluded that the meta-analysis supersedes the results of all these other clinical trials. So again, my point is, p-values are measures of probability, measures of statistics, and they should not be used, in my judgment, to say yes or no. It's just a measure of probability.
So I understand on that note that there's a new omega-3 fatty acid on the market. Maybe that'll help drive some of the prices down on the current prescription brands. Can you tell us a little bit about that? And also a little bit about how's it different from what we already have?
Yeah, and I think that fits into exactly what you're talking about. There's this AMR 101, its trade name's FACP, but it's AMR 101. It's an EPA-only drug. So as you know, the current prescription omega-3 fatty acid contains EPA and DHA. But this only has EPA. And what's really interesting is that if you look at patients with high triglycerides administered, the AMR 101, the triglycerides go down, as you would expect, but the LDL cholesterol does not go up. And as you know, particularly in patients with very high triglycerides, when you administer fish oils, EPA and DHA, sometimes that LDL cholesterol can really go up. In addition, there was a reduction in ApoB, with Apo being one molecule in every atherogenic lipoprotein, and that's a finding that's very inconsistent with EPA and DHA. So the point is, there does appear to be differences when you use EPA alone versus EPA and DHA. But the really exciting thing is that the AMR 101 development program includes an outcomes study, okay, looking specifically in patients who have high triglyceride levels. And what's really striking is that all these decades that we've used fibrates and fish oils and these things to lower triglyceride levels, and these drugs are used and approved to treat high triglyceride levels, we have never done a dedicated, prospective clinical trial looking at a lipid-altering drug's effectiveness in hypertriglyceridemic patients. And I think it's well past time that we did, and I'm just very encouraged that we now are going to have kind of that definitive study in hypertriglyceridemic patients, again, with the administration of this EPA-only agent.
If you're just tuning in, you're listening to ReachMD. I'm Dr. Alan Brown, and I'm speaking with Dr. Harold Bays regarding the evolving treatments for lipid management. So continuing on in that vein, Harold, I have often thought that we might have had different results with CETP inhibitors if we looked at patients with high triglycerides who are using their CETP as opposed to patients who have more normal triglycerides who probably aren't using that pathway very vigorously. And certainly we talked a little bit about that with niacin, and even in the fenofibrate and other fibrate trials, those seem to be the patients that gave us better outcome. So with that said, that's a good segue into cholesterol ester transfer protein inhibitors, or CETP inhibitors. Where do we stand with the CETP inhibitors in 2012, and what can you tell us about current trials that are underway?
I think it would be an accurate characterization that the pursuit of CETP inhibition towards reducing atherosclerotic event has thus far been challenging. The initial one that was most aggressively evaluated was torcetrapib, and it had dramatic improvements in HDL cholesterol and substantial reductions in LDL cholesterol. The HDL cholesterol went up by over 100%, and the LDL cholesterol went down, depending upon the trial, about 30%. So everybody was very excited. Unfortunately, if you added the torcetrapib to a statin, in this case atorvastatin, then your risk of atherosclerotic cardiovascular disease was actually greater than if you had just taken atorvastatin alone. So that was very disappointing. And then we followed that up with dalcetrapib, which, inhibited CETP a little bit less, and the thinking was, well, maybe we shouldn't be, inhibiting CETP quite as much. Unfortunately, that agent was discontinued from development earlier this year due to lack of efficacy, or what they call futility. So the thinking now is that the torcetrapib, the reason that it may have had adverse effects on cardiovascular disease is that it might be molecule specific, that it might have effects upon the adrenal gland and mineralocorticoids, and increase in blood pressure. And if you could just find something like torcetrapib, but that didn't have these off-target effects, everything would be all good. And so now we're evaluating the anacetrapib, which seems to have very favorable effects upon HDL cholesterol yet again, and the reductions in LDL cholesterol yet again, except there is no evidence thus far that it has these mineralocorticoid, adrenal, increase in blood pressure effects. And so now we're in the midst of this REVEAL trial, which is an outcomes trial that's hopefully going to give us a definitive answer if anacetrapib is going to be the CETP inhibitor that's going to move forward.
Great. So let's talk about some of the other exciting new agents, which as long as it stays nebulous about using HDL as a target, we'll just have to wait and see. I mean, even some of the genetic studies are suggestive that, raising HDL may not be the best target, and I always say HDL is a lot like psychiatry. Half of what we know is correct, and nobody knows which half it is. So we just have to wait and see what shows up. But let's get back to what we do know, which is LDL lowering seems to work in all patient subgroups. And I know there are some new lipid-altering agents, antisense agents, and also some monoclonal antibodies. Can you tell us a little bit about those agents in studies now?
Sure. The first one, as you mentioned, is the antisense drug, the mipomersen, and there, what mipomersen does, it's antisense towards the development of the ApoB. Okay, so it specifically targets a protein. The advantage there is that you are surgically, attacking the apolipoprotein that is found in atherogenic particles. So the hope is that you would avoid, what they call collateral effects that you often find in less specific type therapies. So that's a very interesting approach, the antisense approach. Very interesting. Now, of course, it may have its potential downsides, which would be injection site reactions because it's given as an injection, and increase in liver enzymes, and those things are all being evaluated in clinical trials. But then we have we also have a new class of agents that we're doing many trials, the PCSK9 inhibitors. And what PCSK9 is a moiety that helps in the degradation of the LDL receptor. Okay, so what's really exciting, at least to me, what's really exciting about the monoclonal antibodies to the PCSK9 is that by inhibiting the degradation of the LDL receptor, you would have enhanced LDL receptor activity. And I think you alluded to this correctly earlier on when you said, here's a mechanism for which we are familiar. I mean, many of your listeners probably know the very oldest drugs that we evaluated were the bile acid sequestrants, and one of their major mechanisms of action in lowering LDL cholesterol is that they increase LDL receptor activity. Ezetimibe is a cholesterol absorption inhibitor. One of its main mechanisms of action is that it increases LDL receptor activity. And then we have statins, the most commonly used lipid-altering drug, and its main mechanism of action towards reducing LDL cholesterol levels is the fact that it increases LDL receptor activity. So the PCSK9 inhibitors, the monoclonal antibodies to PCSK9, is kind of attacking, this very same sort of mechanism of action, And I think for investigators such as myself, we feel very comfortable with that particular mechanism of action.
So we've talked about the antisense technology with mipomersen, which is basically a drug that interrupts the translation of messenger RNA for the protein ApoB. And then we've talked about antibodies directly towards this moiety, as you described it, the PCSK9, that binds with the LDL receptor and facilitates its degradation. So by using an antibody to attack that, the LDL receptors hang around longer and have more expression on the surface of the cell. Both fascinating. And now there's some other agents that work with slightly different mechanisms that are also quite exciting, right, such as lamidipide. So can you tell us a little bit about that agent?
Sure. Lamidipide, people may not realize this, but these types of drugs have been around for a while, and I would say decades. And what lamidipide is, it's what we call microsomal triglyceride transfer protein. And MTP packages those triglycerides into your lipoprotein particles, like the very low density lipoprotein, VLDL particles. Okay, so if you block that, then you don't have the secretion of these VLDL particles, and then thus, from a downstream effect, you don't have the creation of the LDL particles because they come from VLDL particles. What's very interesting about this development program is that a decade or so ago we were doing these studies, but we were using doses that we thought would rival that of we were using doses we thought would rival the lipid effects of statins. But unfortunately, not only does MTP inhibitors inhibit the triglyceride secretion from the liver, but it also impairs that triglyceride uptake from the intestine. So you can imagine what happens is if you're not able to absorb fats in the intestine, that can be quite problematic, and then you have a fat buildup in the liver, and that's a problem. But then they said, and this was after the advent and development of ezetimibe, they said, wonder if we used lower doses, maybe more tolerated doses, perhaps we could get clinically meaningful improvements in lipid levels, but we won't have as much of these adverse experiences. And I think that's the model for this drug development, where you're getting LDL cholesterol lowering, you're getting some triglyceride lowering, but you're not having near as many of the adverse experiences that I previously described.
So unfortunately, we're out of time. I've really enjoyed this interview, and I want to thank you very much, Dr. Harold Bays, for all your insights on the newer agents, and I really appreciate you taking the time to do this interview today.
Well, thank you very much.
And I'm Dr. Alan Brown. You've been listening to Lipid Illumination, sponsored by the National Lipid Association on ReachMD. Please be sure to visit our website at reachmd.com, featuring podcasts of this and other series. Thank you very much for listening.